Yep, going live.
Thank you very much. Good afternoon. Welcome to the Public Health and Minority Health Disparities Subcommittee. Thank you to all the members for your timeliness. We have, for your edification, we have 9 bills that we're considering today. Yes, it is indeed crossover week. So we're going to start, we're actually going to start with House Bill 977, which is the Maryland Department of Health Office of Chief Medical Examiner. Because that is
mine. Sorry, I just got in.
Oh, I'm sorry. Would you rather us start with another bill? Okay.
Nope, I've got it.
Okay, perfect.
Okay. So House Bill 977 establishes the Office of the Chief Medical Examiner as a unit within the Maryland Department of Health to advance forensic science through medical education and research as staffing allows, and to carry out any other duty established in law. The bill redesignates the State Postmortem Examiners Commission to be the Postmortem Examiners Advisory Committee, which must advise the Secretary of Health and the OCME on the implementation of the Postmortem Examiners Commission subtitle. There are amendments that were distributed that just make a few technical changes.
Thank you, Lisa. Are there questions on this bill? Can I have a motion on the amendments?
Move the amendments.
Can I have
Second.
a second? Oh, it's been moved and seconded. All in favor of adopting the amendments, say aye. Aye. Anyone opposed? Go ahead and raise your hand in the chat so I can see it. All right, it passed. The amendments passed unanimously. Do I have a motion on the bill?
Motion.
Move the bill.
Move the bill.
Do I have a
Second.
second? It's been moved and seconded. Thank you very much. Any discussion?
Followed by pound.
All right, all in favor, please say aye.
Aye.
You have not
Aye.
entered
House Bill 977. Anyone opposed? Go ahead and raise your hand. Seeing none, this bill passes unanimously. Thank you so much. And thank you, Lisa, for being here. We are now going to move to House Bill 811. And I just have to get mine. And Erin, if you can talk us through the bill.
Sure. There's a reprint of this bill that was provided to you. I'm just going to work through the reprint. And the reprint incorporates amendments that have been offered by the bill sponsor, is Delegate Vogel. The first amendment changes the name of the title to the Josh Symes Act. Then if you go on to the text of the bill, it requires that if an individual is treated at a hospital and the hospital conducts a urine drug screening to assist in diagnosing the individual's condition, the hospital shall include testing for fentanyl in the individual's urine drug screening. If the drug screening that's conducted detects fentanyl, the hospital is then required to report the test results to the Department of Health through the state designated health information exchange. The bill also provides that it does not apply to a hospital that does not have chemical analyzer equipment. And then the final section of the bill provides that that it does not affect any state law providing civil or criminal immunity to an individual who is in need of medical assistance after ingesting or using alcohol or drugs, or to an individual who in good faith assists another individual who is in need of medical assistance after ingesting or using alcohol or drugs.
Thank you very much. And just for our edification, these amendments that the Maryland Hospital Association is in support of the bill as amended. Is that correct?
Correct.
All right.
State designated information exchange.
All right. Let's go ahead and move the amendments, and then we'll open it up for discussion. Do I have a motion to move the amendments?
Move the amendments. Second.
All right. They've been moved and seconded. All right. Let's go ahead and open it up for discussion. Delegate Hill.
Okay, thank you. Unfortunately, I don't have the amendments in front of me, so I'm looking on another email. So I was under the impression, I'm just trying to get a sense of what this bill is supposed to do. My impression was the idea was to have testing done so that the patients in the ER would have the information they needed to know what they need to do, and not so much that this was testing for reporting back to the state. But it sounds like, Erin, from what you said, the primary purpose isn't about the patient knowing, you know, it was fentanyl in my stuff, don't use that stuff again, and preventing their deaths. It's about the state finding out what's going on?
I think why this was added was because the bill as introduced just required this testing, and this would be a next step so that something could be done with these results. Perhaps the OOCC could get these results and see spikes in areas where fentanyl is showing up. So it was just a next step to, you have the results and let's do something with these results.
So I know we've had issues before when we were tracking locations. There were issues. In fact, Baltimore City came back last year with a bill because there was information about whether EMTs were sharing personal information about the people. And I understand this is protected, but is that what we need to do? Do we need to have something tracking? I mean, first of all, it's weird for us to be sort of legislating testing, although we do it for newborn screening and all that. And I guess I'm asking for the sense of the committee, are we really trying to get away from making sure people are appropriately diagnosed so they can be safe? Do we need to turn this into some tracking mechanism for the state?
Madam Chair, can I say something?
Yes, go ahead, Delegate Lewis.
So thank you, Madam Chair. So Delegate Hill, my understanding of the bill is that it gives the state information about where fentanyl is, spot testing people who are in the emergency room, gives the state information about where fentanyl is circulating in the drug supply. It's not about tracking individuals, and it's about getting information about where fentanyl is. And I think that's a worthy goal, and I don't see the problem with it.
Madam Chair, may I add something too?
Yes, go ahead, Delegate Hutchinson.
So Delegate Hill, I actually think I asked this question, or somebody did, and either in committee or maybe when I met with the family directly. I think what they were saying is that the standard of care or what they would have done to the patient in the hospital wouldn't change either way, fentanyl or not fentanyl. And that was just a reporting mechanism to track fentanyl use in Maryland.
Well, you had the conversation, but my understanding is that one of the things that was important to know for people, and I think in one of the witnesses, it was about their loved one left the hospital not knowing the drug they used had fentanyl in it, then went back and used the same drug again. So by not testing, people don't
go ahead,
know,
Delegate Hill. Yeah.
they can't change their behavior, and they're setting themselves up. Yes, you're right. Like Narcan is given for narcotics. It can be for, so it can make a difference in the treatment you're getting. If you know that it wasn't just, marijuana, but it was marijuana laced with opiate, with fentanyl, that's a different treatment than if it's not a fentanyl. Same thing with other drugs, meth or anything else. So knowing that it's fentanyl can change what happens in the ER, and it can certainly change what the person being discharged does in terms of where they get their supply and what they do next.
And I agree with you, Delegate Hill. I think that this bill is attempting to do both. It's attempting to ensure that those screenings are being part of the diagnostic screenings in hospital settings. But then we also need to know the breadth of the issue. But also, we kind of need reporting to hold the hospitals accountable to make sure that screening is actually occurring, if that makes sense.
Yeah, I'm not quite sure I followed that last part, but I would ask Madam Chair, and I guess Aaron, you both would remember the issues we had with the automated system, the centralized system where we were reporting when people were being picked up, or EMTs were responding to them. And I'm assuming, because again, I don't have him that this is clear, that there's no information being reported to the state about the who, the what. There's nothing that's going to track the person at all, correct? Because Aaron, you remember these issues we had?
Yeah, we have.
Can you speak to that?
Ben on the call. I think he knows he's with the state designated health information exchange and could talk about how this information would be provided and protected.
Craig,
that
can we
helps.
go to you and then we'll go to Delegate White? Craig, can you speak to, Mr.
Sure.
Vem, can you speak to that?
Yeah, I'd be happy to. Thank you, Madam Chair. So basically, the lab results already flow from hospitals to CRISP in standard feeds that have been live for a very long time. These will include kind of any of the specific codes that are searched for within the labs, and we protect the data like we protect any other data. There's the option for an opt-out, although if certain laws don't allow for that, then we wouldn't opt out from state reporting. But we don't have any separate concerns over the data flows or the security or privacy.
And it would be used.
So the labs are currently already displayed for other treating providers. So if you look up a patient and they had a history of overdose, or they had this lab information that would be in their record, this law would would ask us to also forward it to the state for reporting purposes.
But not just the aggregate de-identified information that this hospital had so many fentanyls, not anything else, right? Which you're forwarding, because you're having it as one thing, where it's being forwarded to and what they do with it is the other.
Correct. We would forward essentially the minimum necessary to comply with the law, which in some cases is the actual patient record for certain reportable conditions. In this case, I would defer to whatever ends up passing in the final legislation.
And I would ask that we get that clarified, Madam Chair.
Thank you, Delegate Hill. And before we go to Delegate White, Aaron, do you think that's something where we could clarify in there that it's de-identified?
We can. I mean, that's what Craig stated, that's current practice, sure.
Would that suffice, Delegate Hill?
I think so. I mean, we want to know locations. We don't need any other, we're trying to find out if there's a spike somewhere. It's good to know. We don't need to know who the people are. So de-identified aggregate information, I think, would serve that purpose. And Mr. Beam, you deal in data. Does that sound, if we're trying to just locate where the problems areas are, would that be sufficient?
Yes, we can do that.
Okay, thank you. And Delegate White.
Yes, thank you, Madam Chair. I just want to make sure that I understand this correctly. It seems like it's broadened in scope a little bit, where it's really any individual who's being treated at a hospital where there's a drug test ordered would be screened here. Not that it would, again, be specifically targeted to an individual for known or suspected drug use. So it's a bit more universal. Is that fair to say? Is that correct?
Yes. If the screen is conducted, then, and it's a positive result, then the mandates of the bill come in where they have to report that result.
Okay. All right. No, I see that as a good thing, because just because there's someone who may be suspected or known, you may be missing people who wouldn't otherwise present in that way. And so I just wanted clarity on that. Thank you so much, Madam Chair.
You're welcome. Thank you. And I'm just trying to read, there's something in the chat. It's both, we need good information. Oh, yep, that's exactly, thank you. That's the answer to Delegate Hill's question too. It's both, we need good information for discharge, personal decision-making, and healthcare. Also, good numbers allow for investment in treatments, development of health interactions, should not have identified records. Yep. So I think, so I know that we're adding a little bit to the amendments. Is the committee comfortable in voting on the amendments with the understanding that we are going to sort of beef that up a little bit and say that it's de-identified information?
I would move the amendment with the conceptual modification.
Thank you. Do I have a second?
Second.
All right, it's been moved and seconded. All in favor of the amendments, say aye.
Aye.
Any opposed? Go ahead and raise your hand. All right, seeing none, do I have a motion on the bill as amended?
Move the bill as amended.
Do I have a second? All right, it's been moved and seconded. All in favor, say aye. Any opposed? Go ahead and raise your hand. All right, it passes unanimously with the understanding that we are going to amend it further, just to clarify that will be de-identified information in the records, in the reporting. Thank you so much. All right, we are going, that was 811. You are very welcome. Thank you for being here. We're going to move on to House Bill 869. Aaron, if you can talk us through the bill.
This bill would require the Maryland Department of the Environment, in consultation with the Maryland Department of Health and the Maryland Department of Labor, to conduct a study on the impacts of death care and funeral practices on the environment and public health in the state. There is an amendment that has been, there's a reprint of the bill that has been provided. And I need to find it because I can't find mine. We went out of order and it messed me all up. Hold on one second, please. Sorry. I'm gonna find the amendment that was sent. I can tell you that it cuts all of the bill, the beginning, and it ends up at $100,000, but I'm trying to find it. Sorry, bear with me.
Heather, you read it.
There you go. Hold on, I have it. Nope.
Sorry, didn't mean to.
I got it. I can get it.
All right,
got
thank
it.
you.
Okay, so the reprint would cut several provisions in the bill. So what you are left with is that MDE, in consultation with the Department of Health and Department of Labor, will conduct a study of the impacts of death care and funeral practices on the environment and public health of the state. The study will examine the environmental and public health impacts of the following death care and funeral practices: casket and vault burial, mausoleum burial, casket-only burial, natural or green burial, cremation, alkaline hydrolysis or water cremation, resumation or natural water cremation, and natural organic reduction. The remaining provisions of the bill have been stricken. And with these amendments, MDE sent a revised fiscal estimate of $100,000 to conduct the study.
Thank you very much, Erin. Can we go ahead and move the amendments and then we'll have discussion? Do I have a motion?
Move the amendments.
Do I have a second?
Second.
Thank you. And is there any discussion on the amendments? Seeing none, they've been moved and seconded. All in favor, say aye. Aye. Any opposed, go ahead and raise your hand. All right, seeing none, do I have a motion on the bill as amended?
Move the bill.
Do I have a second? All right, it's been moved and seconded. Delegate Riley. Delegate Riley, you're muted. We all do it.
Thank you, Madam Chair. Sorry about that. So on this bill, I didn't see, like, when I was going through the, testimony and everything, and I didn't see a lot of information from like our, small businesses that actually do this on a daily basis. So I have some feelers out. So at this time, I will be voting no on the bill. May change my mind later on after getting additional information, but just wanted to let you know.
Okay, I appreciate that.
Thank you.
Delegate Chisholm.
Thank you, Madam Chair. And thank you, Aaron, for the note or the comment on the fiscal note. But is MDE the only one left in the bill?
No.
You said that they revised their number, but there's other.
Well, it's their responsibility. So it's MDE in consultation with. So it lies on them ultimately.
Okay, thank you for the clarification.
And Delegate Riley, if you have further concerns that we can address as a committee, just let me know and we'll get answers for you. So the bill as amended has been moved and seconded. All in favor, say aye. Aye. Anyone opposed, go ahead and raise your hand so we can record it accordingly. I have Delegate Riley. All right, thank you very much. All right, thank you very much, everyone. It passes not unanimously. but pending further information. All right, we are now going to move to House Bill, we're going to move back to House Bill 48. Erin, if you can walk us through the bills or walk us through the bill.
This bill repeals the collaborative care pilot program and instead requires the Maryland Department of Health to expand access to and provide reimbursement for services that are provided in accordance with the collaborative care model under the Maryland Medical Assistance Program. There were no amendments offered at the bill hearing.
Thank you, Erin. This bill, I believe, passed second reader in the Senate. There are no amendments. So do I have a motion on the bill?
Move the bill.
Do I have a second?
Second.
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 All right, bill has been moved and seconded. All in favor, say aye. Aye. Anyone opposed? Go ahead and raise your hand. Delegate Riley, did you have a question or you're opposed? Oh, you're muted.
So questions first, is that good?
Yeah, did you have a question? Go ahead.
I did. Yeah, so on this one, hold on one second. Hold on. 48. That's good. Okay, so this is the one with that we're currently in the pilot program, I see. So I think one of our question was, why don't we wait? But then I did see the letter from MDH, and they did a earlier report, and it sounds like everybody's on board, and it does actually encourage them to get help quicker, which does again is cost effectively. But the fiscal note is still pretty meaningful. So I guess there were no amendments, obviously, to try to get that fiscal note down. So that was one concern. And again, it is mandated funds. Another question I had, and you probably can answer this, I don't really know. So in the Maryland Department of Health letter of information, when it talks about Medicaid, the federal funds and the state funds with the split. So here in Maryland, when we make mandated funds on Medicaid going forward, and in their letter, it said, so the state funds would automatically go up by 8.2 million every year. Now that's every year. And then the remaining 12.8 million comes from federal matching funds. When we do that, is that an automatic thing, or is that something that the federal government looks at? I don't know.
Erin, did you want to answer that? You want me to take?
You can, or the department's on, because it varies in terms of the level of the match.
Okay.
Yeah. But that match is part of the collaborative care model, which is actually why because there was a favorable with amendments originally in the testimony from the Maryland Psychological Association. Sorry, I always get them and the Psychiatric Society mixed up. They have actually withdrawn that amendment request because they now understand that collaborative care model is what makes us eligible for the matching funds.
Okay, so there are criterias in each.
Correct.
Okay, so that makes sense then. Okay, so there shouldn't be any problem with them, going forward with this if we pass this legislation. Okay,
No.
Sounds good. One other question. So this is similar to the model that we have with primary care for other purposes, and we're adding the behavioral health.
That's exactly what it is. It's behavioral health in primary care settings.
Okay. So when it's behavioral health in primary care settings, are those people are they counselors, or are they the physicians? Are they psychologists? How does that work?
It's actually a model that is it's a care coordination model. So the primary care clinician is still responsible for making the model, but
and then they refer, or
they can have on-site services or referral services, but they have a referral relationship.
Okay, thank you very much. I appreciate it.
Absolutely. Are there any other questions on this bill? And it's been moved and seconded. All right, all in favor of House Bill 48, please raise your hand, say aye. Anyone opposed? Go ahead and raise your hand. All right. House Bill 48 passes unanimously. We are now going to move on to House Bill 271, 988, Trust Fund funding. And thank you all for helping. We're halfway through. Go ahead, Erin.
This bill requires the governor to include in the annual budget bill for fiscal year 2025 an appropriation of $12 million to the 988 Trust Fund for the purpose of designating and maintaining 988 as the universal telephone number for a national suicide prevention and mental health crisis hotline, and for developing and implementing a statewide initiative for the coordination and delivery of behavioral health crisis response services in the state. There were no amendments.
And this bill passed the Senate unanimously. So can I get a motion on the bill?
Move the bill.
Can I get a second?
Second.
Thank you. It's been moved and seconded. Is there any discussion? Delegate Riley, go ahead.
Sorry, me again. Okay, so looking at this one.
This is where we do it. This is where we have these
Okay.
things.
All right, looking at this one, again, mandated appropriations. So this one, it says your local revenues and state would probably go up, which makes sense when you go through there. But my main question, so apparently this fund, the 988 Trust Fund, says that it's possible that the jurisdictions that actually operate the crisis call centers or the MCI centers and so on and so forth. It also says other acute behavioral health care services can actually be awarded monies from this to, for their local jurisdictions. I was just wondering, so in Hartford County, we have one that, every year we struggle for additional monies because a lot of these behavioral health crisis centers, don't necessarily pay for themselves, but yet, it's a good, treating and resource for our folks that have opioid, or in opioid crises. So we have I believe, Madam Chair, that you're familiar with it, the Klein's Family Hartford Crisis Center, which is basically a mental health and addictions issues and helps folks like this. Would they
That's extraordinary.
qualify? Would they qualify for a grant from this fund?
So we have Dan Rabbit on this call who's been working on the 988 Trust Fund. He might be able to answer that question.
Give us a better idea.
Sure. Yeah, happy to. Good afternoon, delegates. Hello, Delegate Riley. The parameters of the 988 Trust Fund are mirrored off of the congressional act that established 988. So in that, it said like what 988 funds can be used for, and we use the exact same language. And that is the 988 call centers themselves, mobile crisis teams, crisis stabilization, and other like urgent behavioral health care services. It's sort of a catch-all that was in the federal bill.
Okay.
So the crisis center you speak of, I think, would be eligible. The Behavioral Health Administration administers the 988 Trust Fund, so they're the ones that make the decision under law. We think that the 988 call centers should be first in line, just because they're sort of the front door to all of the other services. But the trust fund was designed to be flexible to support the continuum of services.
Okay, all righty. Thank you so much.
You're welcome. Delegate Chisholm.
I'm sorry, but I'm glad Dan's on here for this. So the money comes in from the federal government. Am I correct on that? And then it goes into a general fund. The question now is whether it's mandated to the 988, Maryland 988 or not. Am I correct?
This is state general funds. Some federal dollars come down for 988, but not nearly enough to support the whole network in the state.
So when you say some, can you give me a ballpark?
The state has received $2.8 million in the last 2 years from the federal government to support 988 services.
Okay. So when I'm looking at the Department of Health, they're asking that the funds, and this doesn't have to be for you, are not mandated to go towards the crisis lifeline. So would that mean that the money's still in the budget, but that the money could be taken out of the budget?
I don't know if there's someone from the Department of Health who wants to comment on their letter.
I don't think we have anyone from the Department of Health. The Department of Health was supporting this effort. Actually, Marie Grant.
Thanks, Delegate Bagnall. I just wanted to make sure folks knew I was on. It is day one with the department, so I want to take back and answer this question and understand the positioning here, but just wanted to let you all know and happy to help follow up on any questions.
Okay, thank you very much. So Delegate Chisholm, it sounds like we're going to need a follow-up. I think the intention of the bill is that this money go for the 988 funds. The dollar amount came from a SAMHSA funded analysis of what Maryland would need to have capacity, to the capacity necessary for timely responses. And the goal of timely responses is 90% plus of Maryland calls from Marylanders being answered by Maryland call centers.
Okay, I just worry about misappropriation of funds at times. Not that we've never done it in the past, but I want to make sure the money that's designated for that 988 number goes to the 988 number in the future is my only concern. So
I appreciate it. We can do a little more digging to make sure we've got an answer to your question. Are you comfortable voting on the bill, knowing that we're going to confirm that the money is going where intended?
Yes.
All right. Thank you very much. We have, I think we've been moved and seconded. And this bill has no amendments. So all in favor of House Bill 271, say aye. Aye.
Aye.
Anyone opposed? Go ahead and raise your hand. All right, that passes unanimously with the caveat that we're going to get a little more information for Delegate Chisholm for discussion when it gets to our full committee. Let's go ahead and move to House Bill 322, Public Health, Home and Community-Based Services for Children and Youth. Erin, if you can walk us through the bill.
This bill requires the Maryland Department of Health to expand access to and provide reimbursement for specified wraparound intensive in-home and case management services related to the Section 1915I Intensive Behavioral Health Services for Children, Youth, and Families program. Beginning in 2024, the Behavioral Health Administration must fund 100 slots in the mental health case management program for children or youth who are not eligible for Medicaid services and are at risk of out-of-home placement. The governor is required to include in the annual operating budget bill the following amounts to fund customized goods and services for youth receiving services under the 1915I model or mental health case management program. $150,000 in fiscal 2025, $250,000 in fiscal 2026, and $350,000 in fiscal 2027 and each fiscal year thereafter. There is a reprint that was provided that incorporates an amendment offered by Delegate Bagnall, and this strikes language in the bill that would have required ensuring that all Medicaid eligible children would be eligible for 1915I model services. You're muted, Delegate.
No, I'm doing it. No, I'm doing it. Thank you so much, Erin. All right, let's go ahead and move the amendments and then we can have discussion. Do I have a motion on the amendments?
Move the amendments.
Do I have a second?
Second.
All right, amendments have been moved and seconded. Any discussion? Delegate Riley, go ahead.
All right, got it that time. 3 times the charm. Okay, thank you, Madam Chair. So on this one, so during the hearings, I had marked down that there was concern and that as the sponsor was going to look at maybe amending the bill that would affect the take the retailers out. We're on 322.
I don't think retailers were involved in this.
Yeah, I don't think the retailers were involved in this bill.
All right, I might have read it on the wrong one. Hold on one sec. 322. No. Oh, okay. No, sorry. It's the wrong one. This one was, well, of course, the dollar amount. And then the other one was, does this jeopardize in the Department of Health? It talks about the program, the 1915 program. And they felt that if this would pass in its current form, that it would jeopardize that program. Have we looked at that?
So that's the amendment that we
Okay.
offered. When it was originally drafted, it was drafted in such a way that it made all Medicaid recipients eligible for the 1915 I waiver, which was not the intent of the bill.
Okay.
So we've amended it to limit it to define those adolescents who have the highest need and meet the other eligibility criteria. And we've also limited it to 100 slots to make sure that that we have control over the program.
Right. And currently we have a little shy, less than 100. So adding a few more. Okay. All right. Thank you very much.
It also adds reporting requirements. It also adds that care coordination piece, which has been sort of the piece that's been lacking in making sure that eligible youth were actually accessing these services.
Okay. Thank you.
Madam Chair.
I recognize the voice.
Delegate Hutchinson.
Delegate Hutchinson, go ahead.
Just in that amendment, what we just had that discussion, that then eliminates MDH's letter of concern then out of that. Is that
correct?
Okay, thank you.
So the amendments have been moved and seconded. Delegate Riley, did you still have a question? Oh, Delegate Alston.
Sorry, all kinds of things start lighting up on my screen. So with the 100 capacity, what happens when more people need the services than slots are available? I guess that's just like currently what's happening. They don't get services.
Ms. Grimes, did you want to respond?
Sure. Thank you, Delegate Bagnall. I just wanted to make sure that we're not crossing two different pieces of the bill. One is there is an addition of 100 slots for TCM Plus, which are slots for children who are not Medicaid eligible to receive targeted case management services. It's an additional slots. These are typically children with private insurance that have high needs, not always, but largely those. The 1915I slots are different. The challenge with the 1915I is it was designed to serve approximately 200 children a year. We have a variety of access barriers that are causing utilization to hover between 11 and 30 kids. Not enough children are accessing that service, but the 100 slots is different.
Thank you for the clarification.
You're very welcome.
I appreciate that because we want to get this right. Did you want, so Delegate Alston, did that answer your question? Okay, perfect. All right, we have, the amendments have been moved and seconded. All in favor, say aye.
Aye.
Anyone opposed? Go ahead and raise your hand. All right, do we have a motion on the bill?
Move the bill as amended.
Second.
All right, it's been moved and seconded. All in favor, say aye. Oh, and sorry, any discussion? No, all in favor, say aye. All right, anyone opposed, go ahead and raise your hand. Seeing none, the bill passes unanimously. Thank you so much, team. All right, we are on to House Bill 570. Let me make sure I'm accurate on my notes. Yes, 570. Erin, if you can walk us through the bill.
On this one, I think it's also best to go through the reprint, which incorporates amendments that have been offered by Delegate Bagnall, the bill sponsor. If you go to page 2 of the bill, after line 9, the bill requires the Department of Health to adopt regulations governing the provision of pharmaceutical disposal systems by dispensers of opioids to ultimate users. The regulations must ensure the sufficient availability of pharmaceutical disposal systems to address the problem of diverted prescription opioids in the state, provide guidance to dispensers of opioids regarding the circumstances under which a dispenser should consider providing a pharmaceutical disposal system to an ultimate user, address the types of pharmaceutical disposal systems that may be provided, and address methods to provide to an ultimate user educational programs and materials regarding pharmaceutical disposal systems. The bill provides that the department may provide personal use pharmaceutical disposal systems to each dispenser in the state, and a dispenser that receives these systems must distribute the personal pharmaceutical disposal systems in accordance with the regulations that are adopted. The bill further provides that the department may procure personal use pharmaceutical systems with funding from the opioid restitution fund.
Thank you, Erin. And Delegate Riley, I think this might be the bill that you were asking about. Those were consensus amendments that satisfy the concerns of the various stakeholders, including the retailers. With that, do I have a motion on the amendment? Let's go ahead and move the amendments, and then we'll have further discussion.
Move the amendments.
Do I have a second?
Second.
All right. Is there discussion? Delegate Chisholm, I saw your hand go up.
Thank you, Madam Chair. So what is a dispenser? Why is it different from a pharmacy?
Because it's not always the pharmacist that's dispensing. So we wanted to make sure that it was, because it can be a pharmacy, it can be a physician. It's anyone who has a license to dispense.
Like an urgent care or something. So, and with all due respect, is this a necessary bill? Do we have a problem with this currently?
This is a proactive bill, but it also allows us to utilize the opioid restitution funds to provide these systems at no cost to the dispenser or the provider or the patient.
I don't have better use for those funds.
Well, I think there are lots of uses, but I think getting some of those second life opioids out of people's medicine cabinets is a good utilization.
Well, I would agree, but once again, I don't know if I've heard any problems with it. We've set up so many programs for this type of thing. And I appreciate the intent of the bill. I'll just hold it there.
I appreciate your comments, Delegate Chisholm. Is there any other discussion on the amendments? They've been moved and seconded. All in favor of the amendments, please say aye. Aye. Anyone opposed? Go ahead and raise your hand. Can I have a motion on the bill as amended?
Move the bill as amended.
Second.
All right, it's been moved and seconded. Is there any further discussion? All right, all in favor of House Bill 570 as amended, say aye. Aye. Anyone opposed, go ahead and raise your hand. I have Delegate Chisholm. Oh, why aren't you showing up in my chat? Hold on, or in my participants? Oh, that's why. Hold on, I want to make sure that I'm seeing everybody. I've got Delegate Chisholm, Delegate Hill, Delegate Riley, Delegate Hutchinson. All right. Thank you very much, everyone. The bill passes not unanimously. Erin, why don't we go to 1149 and then we'll come back to 1148.
House Bill 1149 authorizes funding provided in the fiscal 2023 budget for autism waiver expansions to instead be used more broadly for Medicaid waiver expansions. There is a reprint in your that was provided with amendments that are being offered by Delegate Payne-Melnick. If you look to page 6 of the reprint, this clarifies that of the $10,000 of the appropriation that was made for Medicaid waiver expansions, it would be transferred by budget amendment to a certain budget program. It also provides that the remaining funds of the appropriations made for those Medicaid waiver expansions are to be used to provide community services to individuals waiting for services through the Community Pathways Waiver, the community supports waiver, the family supports waiver, the brain injury waiver, the community, home and community-based options waiver, the medical day services waiver, and the model waiver for medically fragile children. And then a portion of those funds can be used for purposes of expanding program capacity, provider capacity in those waivers, including hiring and retaining staff and providers, increasing provider rates, and addressing other issues that limit provider capacity.
Thank you. Let's go ahead and move the amendments and then have discussion. Do I have a motion on the amendments?
Move the amendments.
Second.
All right, they've been moved and seconded. Delegate Chisholm and Delegate Lewis, I saw your hand up before as well.
Yes, ma'am. I was just going to, no, everything's fine. Thank you, Madam Chair.
Okay, thank you. Delegate Chisholm, go ahead.
So where we had autism waiver expansion, we're going to strike that completely, put in Medicaid waiver. So are we essentially negating those who were once in line for the autism waiver expansion? Because obviously we all know autism's a huge concern and on a trajectory that's almost straight up in the air right now. So are we leaving them unprotected now with this amendment?
Erin, do you want to speak to that, or do we have
So
any?
my understanding, if you look at the bill, that look on page 3 of the reprint, line 14, and that provides for $30 million. So it's my understanding from the bill hearing that 20 million would still go to the autism waiver. And then if you look on bill page 6, it says further provided that at least 10 million of that appropriation would now be able to go to the provisions of the bill, which were to reduce the waiting lists on those other waivers. And I don't believe there was any issue raised at the hearing with people regarding the autism waiver.
So we've talked to the autism advocates and they're okay that now it's going to be, because I don't see the 20 million allocated for autism. I just see 30 million going to Medicaid waiver now. I see the 10 million you're talking about, but it just says 10 million for Medicaid waiver. Is it spelled out anywhere in the new reprint, which I'm looking at, that at least 20 million is going to the autism waiver?
The bill specifies that 10 million will be used for children on registered autism waivers. Essentially, the department is asking for some flexibility, and the advocates are also asking for the flexibility as they get people off of these waiting lists to be able to also build capacity. And so they're just asking for some flexibility within the waiver program. But ensuring that there is money that is dedicated to children registered on the autism waiver, because many of the children age out of the system but still need services.
Okay. Thank you, Madam Chair.
You're welcome. Are there further questions or concerns on this bill? All right, the amendments have been moved and seconded. All in favor, say aye. Aye. Anyone opposed? Go ahead and raise your hand. Can I get a motion on the bill as amended?
Move the bill as amended.
Do I have a second?
Second.
All right, bill has been moved and seconded. All in favor, say aye. Anyone opposed? Can someone send me these reprints? Oh, okay. Yep, Delegate Hill, we see your message. We'll make sure you get the reprints. Anyone opposed? Let me just check my. All right, that bill passes unanimously. Now we are going to turn to our last bill of the day. Just members, so you know what's happening. We still have one piece of this bill that has not been resolved as yet, which is the certified community behavioral health centers. We're still working on that. So we're going to consider the rest of the bill. This is House Bill 1149, the behavioral health model for Maryland. So Aaron, if you can walk us through the bill as it's amended.
Okay, so in the reprint, this bill was discussed last week, and some of the issues had to deal with the composition of the commission. If you look on after line 24 on page 3, the Secretary of the Department of Disabilities and the Secretary of the Department of Public Safety and Correctional Services have been added to the commission. And then if you look on bill page 5 of 18, after line 3, a representative of a federally qualified health center and a representative of a local behavioral health authority and one individual self-advocate with an intellectual disability with experience as a consumer of behavioral health services has been added. So that goes to the changes in membership since last week. And then if you look on page 7, after line 2, there are 2 new duties of the commission. One is to examine and review the use of harm reduction strategies to facilitate access to care, and another is to examine methods to assist consumers in accessing behavioral health services. And if you look in the work groups, those have been slightly adjusted. One of the work groups is now the youth behavioral health, individuals with developmental disabilities, and individuals with complex behavioral health needs. That's on bill page 7, line 6. And then another work group that's on line 9 is the behavioral health workforce development, infrastructure, coordination, and financing work group. Then if you look down to the report, it is now clarified on line 25 that these recommendations that are provided by the commission must be consistent with providing appropriate, accessible, and comprehensive behavioral health services to individuals in the state across the behavioral health care continuum that are available on demand. And the reason why that was added is because it goes back to tying in the recommendations with the purpose of the commission, which is set forth on bill page 5, lines 17 through 20. So that tracks the purpose of the commission. And then the additional amendment is to, at the end of the bill, is a reporting requirement, and that's related to telehealth. And that would require the Maryland Healthcare Commission to study and make recommendations regarding the delivery of healthcare services through telehealth, including payment parity for the delivery of healthcare services through audiovisual and audio-only telehealth technologies. And when they conduct the study, the Healthcare Commission must determine whether it is more or less costly for healthcare providers to deliver healthcare services through telehealth, determine whether delivery of healthcare services through telehealth requires more or less clinical effort on the part of the healthcare provider, to help inform the debate on payment parity, identify the aspects of telehealth that are subject to overuse or underuse or yield greater or lower value, assess the adequacy of reimbursement for behavioral health services delivered in person and by telehealth, and address any other issues related to telehealth as determined necessary by the commission. And this report would be due December 1st, 2024.
Thank you.
Amendments.
They've been moved. Do we have a second?
Second.
Moved and seconded. Before we start the discussion, Aaron, I just wanted to make sure that, because I didn't hear it, but you may have said it, on the amendments on page 6 that expand the recommendations to ensure an adequate, culturally competent and diverse workforce.
Yeah, sorry.
That's all right. And also on line 17, examine and make recommendations to provide appropriate and adequate behavioral health services to individuals with developmental disabilities and complex behavioral health needs, specifically youth.
Yes.
Because those were requests that came from the committee, from the subcommittee, as well as from the advocates. All right, so let's go ahead and open up the discussion. Delegate Rosenberg.
Thank you, Madam Chair. Perhaps this has been addressed by the amendments, but is either the Special Secretary for Opioid Response or someone from the Opioid Operational Command Center on this commission? And should they be?
They are not. So,
I mean, this is an essential part of the kind of public care we're providing.
it is. Aaron, where would that be appropriate? We're at 41 currently.
Yeah,
41
you'd be at
stakeholders.
42, and it would just go under the people who are on by virtue of their position. They wouldn't have to be appointed by the governor.
Appointed by the governor. Okay.
So it would be after 15.
All right, let's just take that up in a moment and see if we have consensus on that. Thank you, Delegate
you.
Rosenberg.
Thank you.
And Delegate Hill.
Thank you, Madam Chair. On page 7, this is also just a little wordsmithing. Lindsay, on line 25, where we've added there that are consistent with providing appropriate, accessible, and comprehensive behavioral health services to individuals. I'm wondering if after services, that's where that are available on demand should go, as opposed to the individuals being available on demand. Health services that are available on demand.
If you want to change that, that's fine. And I'll change that in the purpose and they can match.
Okay, and then I just wanted to know, Madam Chair, if you could just remind us of what is the latter part that we're not going to address today? What's the outstanding part of this bill?
The outstanding part is the community, the certified community behavioral health centers. So that let's move on these bills and I'll walk you through where we are in discussions on community behavioral health centers. Bearing in mind that the Senate has both this bill and they have a standalone CCBHC bill. So they're actually currently talking to the health department about that piece. So can we circle back on the on adding the opioid command center and or Delegate Rosenberg? Yeah. Delegate Rosenberg, your suggestions were. Oh. Delegate Rosenberg.
Sorry, either the special secretary or someone from the command center to become the 42nd representative.
I second that.
Aaron, can you speak to if either or?
If you want to do
Well, you could do this. I'm sorry to interrupt. You could do the special secretary or designate.
Or designate, and then they can come from.
Yeah, that's usually how it works.
Yeah. So let's go ahead and vote on that concept amendment and Delegate Hills as well, that we're going to do some wordsmithing, and then we'll vote on the amendments as a whole, and then we'll have the CCBHC discussion. So if I can get a motion on the concept amendments.
So moved.
Oh, actually, let's go back because we already had a motion on the previous amendments. So we'll vote the amendments.
Madam Chair, these are the amendments to the amendment. So I think we take the amendments to the amendment and then we take the amendment.
Okay. All right. We'll do it that way, as long as we all know what we're voting on. So these are the amendments to the amendments, have been moved and seconded. All in favor of the amendments to the amendments, say aye.
Aye.
Aye. Anyone opposed? All right. And now on the amendments, all in favor, say aye. Oh, can I
move the amendments?
Let's move in second.
It was moved. That's why we were in discussion.
All right, thank you. All in favor, say aye.
Aye.
Anyone opposed? Thank you, and thank you all for helping me with the procedural. We're not going to vote the bill yet because I want to have the discussion on the CCBHC. So I had a conversation this morning with the department. They're now talking to the health department as well. Aaron, have you had an opportunity to review the amendments that they proposed, or do you want me to speak to them?
Melanie, did you get a chance to check the mail yet today?
Delegate Lewis, can you mute?
Okay.
I'm sorry, I have not.
Oh, okay, no problem at all. So I can talk you through what we discussed. The department is asking for some flexibility on the CCBHCs. They're still concerned about making them affordable and making them having some control over the rollout. So what they have asked is if we could alter that section to the 1115 waiver. So the 1115 waiver does not give us the enhanced federal match, but we still have a federal match. It gives some flexibility to the department because it doesn't have to have the exact same standards as the federal certified community behavioral health centers, but they're asking for flexibility so that they can continues to sustain the 5 existing CCBHCs, which are currently SAMHSA granted. They're under a SAMHSA grant, which is going to expire. I have asked the department if we're going to give them that flexibility, if we can include in this bill, which is a 4-year bill, a study on how we would move from the 1115 waiver to the CCBHC model. Which would it would basically be taking what is in this bill now for 2024 and moving it to 2026 essentially, and in the interim ensuring that we have funding for the existing 5 CCBHCs. With that, I see a hand from Lori Doyle who can speak to the CCBHC piece and perhaps where the discussions are as well.
Thank you, Madam Chair. Lori Doyle here on behalf of the Community Behavioral Health Association of Maryland. We're very concerned about going the 1115 route, and we have expressed our concerns to the department, and they really are around the fact that the language, the amendment language that the department has proposed is no longer a CCBHC. What they're proposing, there are 2 prongs that make a CCBHC. One is meeting the certification of the services required by the federal law. The other is the prospective payment system. So what they are proposing is to basically eliminate both and be given the discretion to determine what those services are and how they will be paid. And so we think that this is creating something it's not a CCBHC, it's something else. And so we're going back and forth to see what we can come up with, but we would strongly suggest not going down this road for a number of reasons. Thank you.
Thank you. And we've got Ms. Grant. Go ahead.
Thanks so much. Yeah, I just wanted to follow up and thank you for explaining our position clearly. And, you know, I think our goals are similar to Lori and the folks she's representing. We are excited about CCBHCs as a model. We just want to make sure moving forward in a prudent manner, surrounding. So we want to get to where we're in agreement. We think that 1115 allow us to do that, and we just look forward to working with you on this. Thank you.
Ms. Doyle, go ahead.
Oh, I'm sorry, I just forgot to put my hand down. My apologies.
No problem. Do we have questions from the members about CCBHCs, about where we are, or about any other aspects of the bill? Delegate Alston.
Yeah, I just wanted to go back because I wasn't sure if I fully understood Delegate Hill's amendment. I recall, if the attorney could just run it back for me. I just didn't know if she was if they were deleting from one place and moving to another or copying them in both places.
Yeah, she's just changing where it says that are available on demand. So it modifies the services rather than coming after the word continuum. It's still going to have the same meaning. It's just probably better placement in the sentence because it's the services that should be available on demand.
Okay. All right. Thank you. That was it.
It's more grammatically sound, I think.
Correct.
All right. So we're not going to vote this bill today. We're going to put this bill on the schedule for tomorrow. What I'm going to ask is that the department and Ms. Doyle and our Senate partners that we try and have these discussions so we can come to some sort of consensus for tomorrow, because obviously we are coming up against crossover. This bill is a priority of the chair, it's a priority of this committee, and it's a priority of the speaker. And obviously behavioral health in general is a priority of the Senate since they created a big behavioral health package and actually had this as a standalone bill. So do I have any other comments from the members? We're going to be meeting again tomorrow at 11 at our normal time. And hopefully we will have consensus on this bill so that we can move it. Is there anyone else who would like to be heard on this bill before we adjourn? I see no hands. So thank you all for your great work today. We got through 8 3/4 of bills in just over an hour. So if I can get a motion to adjourn.
So moved.
Second.
Moved and seconded. Thank you all so much for your hard work. Get some water and some rest because crossover is going to be crazy.